We have the pleasure to have some of the world-leading experts on climate change and health with us. This webinar is organized by the Global Climate and Health Alliance. My name is Maria Nilsson and I'm the moderator of this event. I work in northern Sweden at a university called Umeå University, and in the university we have a group of researchers that works in climate and health research. We have 3 speakers with us that I will start to present for you in a minute. They will give a presentation each for about 5 to 10 minutes. And after all 3 presentations, we will use the time for questions from you. So please send in your questions on the Twitter feed using the details that you received earlier on in the email reminder. Our first speaker, who will discuss the health impacts described in the report, is Professor Alistair Woodward, who is a professor of epidemiology and biostatistics at the University of Auckland. His first degree was in medicine, and he then undertook a postgraduate training in public health of population health in Auckland. Public health followed by a PhD in epidemiology. He was head of the School of Population Health in Auckland from 2004 to 2013, and prior to that he was at the University of Otago, Wellington. Professor Alistair's research interest includes tobacco, transport and injury, and climate change and health. He has worked for the World Health Organization throughout the Pacific, and in the 5th assessment report of the IPCC, he worked as a convening lead author of the health chapter. The second speaker is Professor Sir Andy Haynes, and he will speak about co-benefits of mitigation. Sir Andy, who is a professor of public health and primary care at London School of Hygiene and Tropical Medicine, have previously been the director for nearly 10 years. He has worked part-time as a GP in London for many years and as a consultant epidemiologist. He has also worked in Nepal, Jamaica, Canada and the US, and been a member of a number of committees on national and international level. And he was a member of 2 previous IPCC report teams within Working Group 2 and a review editor for the 5th report, Health Chapter. He has been instrumental in raising the profile of the health co-benefits of sustainable development. Our last speaker, who will discuss policy implications and responses of the report, is Dr. Darmid Campbell-Lendrum, who is the Climate Change and Health Team Leader within the Public Health and Environment Department of the World Health Organization. He has played key roles in the 2008 World Health Assembly resolution on climate change and health, and has been a lead author of the health chapter of the 5th assessment report of the IPCC. So can I please welcome Professor Alistair Woodward to start with his presentation. Very welcome.
Well, here I am. Thank you very much, Maria. It's early in the morning here in Auckland. I'm delighted to be part of this webinar. I'd also like to say that I'm going to talk a little bit about the IPCC Health Chapter. But before I do that, I should acknowledge all the people who contributed to that. Andy Haynes, who will be speaking after me, was one of the review editors on this. Kirk Smith was the other convening lead author, and we had a big team of lead authors and contributing authors who helped us with the report, as well as a volunteer scientist, Zoe Chafe, who did an absolutely wonderful job. What I thought I would do with my 5 minutes is first talk a little bit about some of the familiar findings of the report, things that we had talked about, had come up before in the 4th assessment, and then move on and talk a little bit about what's relatively new. So the IPCC findings that were to some extent repeating what had come up in previous assessments. The point that the health of human populations is indeed sensitive to weather patterns and other aspects of climate change in many ways, that climate change is already adding to the burden of disease and illness worldwide. The contribution is small compared with the effects of other factors that are driving the burden of disease, but and difficult to quantify, but we believe it is already evident. The question of vulnerability, we know that those who are most vulnerable to these effects, both present and projected, are those whose health is already jeopardized by climate-sensitive disorders, those whose food supply is insecure, those who are subject to flooding and storms, those who are not well protected against heat. They will be the populations who will be most affected in the future as well. The largest risks, three things that have stood out in the past, and the evidence that's accumulated since 2004, 2006, 2004, points in the same direction. The health problems that relate to undernutrition for those populations that depend on local food production, the effects of extreme weather events, heat waves, floods and storms, and shifting patterns of infectious disease. Many infectious diseases are indeed sensitive to climate, we know that well. What's new about the AR5? I suppose heat receives more attention than it has in the past. That's a consequence of the literature that's grown since IPCC reported last, especially the effects of heat on workers. Not a new topic, but one that has received a lot more attention recently, and we believe is a very important aspect of the assessment. One interesting and potentially controversial aspect of the report is that it pays much more attention to the so-called high-end scenarios. In other words, climate projections that envisage that by 2100 the average global temperature may be as much as 4 degrees above pre-industrial levels. That's a consequence of the fact that there have been no substantial reductions in greenhouse emissions in the last decade, and we're on track really to follow the high-end scenarios, which, as I said, are scenarios that lead to a 4-degree warmer world in 2100. An important point, I guess, is that the 2100 reference point is entirely arbitrary, and the highest of the IPCC scenarios, so-called RCP 8.5, which is what happens under relatively unrestrained use of fossil fuels, envisages that the climate doesn't actually stabilize for much longer, and warming in the 22nd century may go as high as 7, 8 or 9 degrees above pre-industrial. Another point that I think is worth noting in the present report is we've paid greater attention to this question of the balance of gains and losses. There will be some benefits, not just in health, as a result of rising temperatures, and the question is, are they of the same order of magnitude as the losses? How do we know this? Well, I can talk about it later perhaps, but we feel that the literature is firmed up on this, and that we can say with confidence that the losses outweigh the gains already, and that will be increasingly the case, particularly in the second half of this century. Two other points, just quickly. We concluded that the rate of change is a risk factor in its own right. It's not just a matter of how much the climate changes, but how fast the climate changes. That's important for human health as well as for ecosystem resilience. Also, we believe that as the evidence is accumulated, we are in a stronger position in terms of making statements about attribution. This is relatively subtle and complex. Public health has used a standard of attribution or an approach to attribution that's not the same as the natural scientists. But we think, looking at the probabilities, that the evidence is certainly accumulating that it's very likely that climate change is already setting its mark on population health around the world. I think I'll stop there, Maria, and I'm very happy to come back and answer questions.
Okay, thanks. Thanks, Alistair. And I would like now to invite Sir Anne Haynes. Welcome.
Well, thank you very much, and let me also endorse what Alistair said about the contribution of other members of the health team for the IPCC report, and also to thank the organisers for inviting me to say a few words about healthcare benefits. Healthcare benefits then are ancillary benefits of strategies that might be primarily directed at reducing greenhouse gas emissions. But of course, one could also turn that round and say that there may be benefits the other way, in the other direction as well. So strategies to improve health can also reduce greenhouse gas emissions. And there are a number of mechanisms through which this can operate. Obviously, one is through air pollution, particularly fine particulate air pollution. And of course, for example, when you burn coal, you also generate large amount of fine particles. Similarly with transport, particularly with diesel engines. But also there's an increasing body of evidence around short-lived climate active pollutants, particularly black carbon. And there have been a number of studies now looking at what would happen to health if we could reduce the sources of black carbon. For example, from the combustion, the inefficient combustion in domestic circumstances, often in low-income countries. This is important to take into account that, as well as the challenges that are being and are going to be increasingly produced by climate change itself, there are, of course, many people around the world who have no access currently to clean energy, and those people are disproportionately affected by indoor air pollution. And the estimates for that, of those deaths, were produced obviously in the Global Burden of Disease report, and they've been recently updated, and in fact they're somewhat greater in the recent WHO estimates that have been given in the last few weeks, where it's estimated 4.3 million people or so per annum are killed as a result, die prematurely as a result of indoor air pollution. But ambient or outdoor air pollution is also, of course, a major killer in many countries and intimately linked with fossil fuel combustion, as I say, particularly coal, but not just coal. And that's also been shown by both the Global Burden of Disease estimates, which suggest perhaps 3.2 million people a year, and the recent WHO estimates. You can't necessarily add the two figures for outdoor and indoor air pollution together because there's some overlap between them, but they do illustrate, I think, the potential for both reducing greenhouse emissions and also improving human health. But there are also policies in a number of other sectors. Obviously, urban transport is another one of them, both in terms of more efficient engines, internal combustion engines, and perhaps in future, obviously, electric cars and other very low emission vehicles. But also, and probably even more important for health, are those policies which facilitate and promote active travel, that's to say, walking and cycling. Because, again, we do know from the Global Burden of Disease estimates that large numbers of premature deaths are related to sedentary lifestyle. And potentially, the increasing use of active modes of travel is an opportunity to increase physical activity in sedentary populations. And so we are seeing in some cities around the world increases in active travel, but in others it's proving difficult to shift travel patterns. A third area where there's a major potential for healthcare benefits, of course, is food and agriculture. And it's estimated that the food and agriculture sectors may be responsible, if you include deforestation, perhaps around up to 30% of emissions. And there are potentially important opportunities to improve health and to reduce greenhouse gas emissions, particularly through reduced consumption of animal products, particularly those from ruminants that produce large amounts of methane in high consuming populations. Obviously, that doesn't mean to say that all populations have to equally reduce their meat consumption. There are some poor populations, for example, pastoralists, that depend very much on their animals. So one needs to tailor policies in relation to the dietary patterns of the population. And of course, we still don't know fully how to implement those policies. What's the best way of trying to promote population change in diet? It's still a question which is the subject of a considerable amount of research. And then one can also say that, of course, emissions are partly related to population. Low emission per capita emissions are found in many parts of the world, in sub-Saharan Africa, for example. But in the long run, as populations grow and people's aspirations for a better lifestyle increase, then we can anticipate that those populations will contribute more to greenhouse gas emissions. And there have been a number of studies suggesting that satisfying the requirements, the unmet needs for reproductive health services and modern family planning could, in the long run, also contribute to reduced greenhouse gas emissions. Obviously, that's particularly true also in high emitting countries where the per capita emissions are much higher. So there then are a number of policies in these different sectors that could both improve health and reduce greenhouse gas emissions. And taking them into account, valuing those health benefits can help to offset some of the near-term costs of implementing these policies and hopefully make them more attractive to policymakers. Not all policies are beneficial. Of course, it's possible that poorly designed policies could have adverse effects, for example, where biofuels compete with food, for example, and some biofuels don't even reduce greenhouse gas emissions. Other adverse effects might be, for example, houses which are very tightly sealed, very highly insulated, and that can cause an increase in indoor air pollution. So one has to think carefully about designing policies to avoid unintended adverse consequences. But overall, these policies can be highly attractive to policymakers, at least in principle, and add, I think, to the argument that we need to substantially reduce greenhouse gas emissions to improve public health. Thank you very much.
Thank you. Thank you so much, Andy. We'll ask some questions afterwards, but before we do that, we let Dermot Campbell-Landrum present on policy implications, and please start.
Okay, thank you very much for inviting me to take part in this important seminar. It's a pleasure to talk to you and also to follow on from the other two illustrious speakers. So what I will do in my 5 minutes is just to maybe set up a little bit of discussion about the implications of the IPCC report for policy and for practice. And I think the first message that is policy relevant to come out of the IPCC is just the point that Alistair made at the beginning, the reinforcement of the strength of the evidence. So, as he said, much of the work, the evidence that has come out since the fourth assessment report is essentially confirmatory. That we've reinforced, we have more studies, more detailed, better quality studies, for example, of the effect of climate change on nutrition, on diarrheal disease, and on vector-borne disease. So the mere fact that it's the fifth assessment report, it's the fourth time there has been a complete health chapter, and the overall message that we told you it was bad and we're confirming that it's bad is in itself policy relevant. This is a problem that's not going to go away. The evidence is not going to disappear, and so we are going to have to come up with credible policy responses on that. Of course, the more important question is what are we going to do about it? How do we go about designing the policy responses to respond to the evidence that the IPCC has presented us with? Of course, the IPCC itself does not give policy recommendations. It's explicitly forbidden from doing that. But what it does do is to lay out the evidence that should make it easier for policymakers to make policy choices. So it should lay out the implications of different policy decisions. And just to take these in very general terms and relate them to the discussion that's gone on before, the first area, of course, is adaptation, or basically protecting people's health from the climate change to which we are now committed. And one of the messages that has come through quite strongly, I think, from the IPCC, and particularly from the more sophisticated studies that have gone on since the fourth assessment report, is that there has been, I think, a better treatment of climate change in the context of other drivers. So whereas previously there had been a rather simplistic discussion of whether a particular change is caused by climate change, or is caused by poverty, or is caused by poor public health programs, the more recent studies have basically looked at those things in the context of each other, with the general conclusion being that, of course, it's better to be richer. Richer populations, those with stronger public health programs, are protected to some extent, so the poorer populations are more vulnerable, but all populations are vulnerable, so all have to respond. But the fact that we are able to look at the modifying effect of effective public health policies and socioeconomic development actually is very useful from a policy perspective, and it reinforces one of the main messages that has come through, which is that sustainable and equitable economic development is critical to protecting people's health from climate change. It's not about necessarily so much about everybody getting rich, certainly not everybody getting super rich, but the more in which it is possible to pull the poorest populations out of poverty, to provide them with basic environmental health services such as water and sanitation, for example, that's going to go quite a long way to protecting people's health from climate change. And I think what puts climate change in its proper context. But it's more than just general development. Some of the challenges that climate change is presenting us with, for example, rises in frequency and intensity of extreme events, actually call for new approaches, for more targeted approaches. And so, for example, the IPCC points out that strengthening disease surveillance systems, taking into account climate influences on disease and so on, are some of the kinds of targeted interventions that will actually deal with the particular risks that climate change is posing. And one of the things that we need to work on as WHO and as health agencies is to make this as intelligible and practical as possible for public health practitioners. Climate change can seem a somewhat daunting challenge, quite a diverse challenge that's mixed up with many other things. And one of the things we've concentrated on is leading public health practitioners through a process by which they can analyze the vulnerabilities that they have to climate change and actually relate that to basic public health interventions, whether it's supplying climate resilient water and sanitation systems, disease surveillance, and so on. So we have a sort of a program to handle that on the adaptation side. There's a lot still to be done. The second point on what we need to do about it relates to the material that Andy covered on the benefits, the health benefits of mitigation policies. And this is a new area for the health chapter. It's a much stronger area than had been covered in previous IPCC reports. And we think it's extremely important from a policy point of view. As Andy has said, the range of health implications of decisions that can also cut greenhouse gas emissions is huge. It goes from agriculture, transport, and so on. So that gives us the policy scope of the areas in which health professionals are going to have to engage. The other really critical message is that the health numbers are very large indeed. As Andy has said, the numbers from indoor and outdoor air pollution in the range of 3 to 4 million, over 3 to 4 million each. As he has said, adding them together is very approximate, but it's in the ballpark, we think, of 7 million deaths per year from air pollution, which puts it absolutely in the front rank of risk factors to public health, up there in the same order of magnitude as tobacco. So it makes clear that the kinds of decisions we're talking about in energy systems, for example, to cut greenhouse gas emissions, are also massive public health decisions. And it should no longer be acceptable for people to talk about energy decisions, or for economic modelers, for example, to claim they can put a social cost on carbon without taking into account the health implications, because the health implications are so big in numbers of lives lost. But also, if you put economic valuation on them, they basically dominate your cost-benefit calculations. So in those policy terms, it's critical to include health. And then, of course, we need to actually get engaged as health professionals with the individual sectoral decisions of energy systems or transport and so on. We have to recognise that's a challenge. It's not something that public health professionals are used to doing, but it's something we're going to have to grapple with. And then the final point I would make from a policy point of view is that this will only really drive forward if there is public support. If people see that protecting both ecosystem services, protecting the climate system, but also gaining the immediate benefits of cleaner air, cleaner water, and so on, becomes part of the vision that people have for the society that they want, because that is what will give politicians basically the breathing space and the support to drive forward policy change. So that public support, in fact, the work that this kind of seminar is doing, this kind of outreach, is absolutely critical as well. So I'll leave it there, and like the other speakers, I'm very happy to engage in discussion afterwards. Thank you.
Thank you so much. Then I invite you others also to come forward to have some discussion. Participants has sent in some questions for us to discuss, so I would like Alistair and also Amy to come up on screen, and we will have a discussion based on those participant questions. And one that has been sent in by several people is about adaptation measures that you have already talked a bit about. And of course, it depends on what part of the world you are in, what kind of adaptation measures that are the most significant. But you mentioned the need of surveillance, of course, but are there more general adaptation measures you could talk about? And is there also some more specific adaptation measures found to be very central in the work? Who would like to start?
If that's okay, perhaps I can start very quickly on that. On the adaptation side, I think there are both general and specific measures. It's very clear, and the IPCC has reinforced the fact that if you have water sanitation systems that function, you're in a much better position than if you don't. If you have basic public health infrastructure, you're in a much better position than if you don't. If you have coverage of bed nets in areas which have suitable for malaria transmission and so on. And these are some of the general measures that of course are going to help protect people's health from climate change. But at the same time, if we also see the increasing frequency and intensity of heat waves, for example, in urban populations that are growing very fast and are also becoming tending to age as well. So the most vulnerable populations for heat stress, for example, are multiplying in size at the same time as heat waves are becoming much more common. And that is certainly a new scale of challenge. And so in that case, we do have to put a lot more effort into specific interventions for that specific threat, such as heat health warning systems that give public health messages and so on that allow people to respond. But I'll hand over to the others as well.
Mm-hmm.
Maria, if I could chip in here.
Yeah, please do.
Just to illustrate Diamit's point, in the Pacific, there are plenty of examples of states that require public health improvements. In Kiribati, for example, where I've been working, the issue of protecting the water supply is already a major challenge, and we know that the pressures on the supply of adequate amounts of safe water are going to intensify over the next few decades. So that's an example of the first response, which is trying to provide for strong public health systems of the basic kind that we need anyway, but become even more important in a threatening environment. The second example is what's happening in Australia. There you have one of the wealthiest countries in the world with, on the whole, not in every instance, but on the whole, very good public health systems, and yet they are sorely tested by climate. And we saw in 2009 with the bushfires in Victoria and the heat waves, and then subsequently, in fact, every summer, the temperature records have been breaking records, and it's clear that there's still vulnerabilities in Australia in terms of their exposure, which require them to think in a different way about how to deal with issues such as heat and drought and fire.
And different warning system, I suppose, also is something that will have to be worked with in the future. What do you say about that?
Perhaps I could just add a few words about considering the limits to adaptation. Because obviously we have to adapt as best we can to the Committee of Climate Change, but there are going to be limits to adaptation, and there may be geographical limits, some small island states, for example, low-lying atolls, but there may be also some health outcomes that are more difficult to adapt to than others, and I'm thinking particularly of thermal stress as it affects labour productivity. It's not so easy to think how low-income subsistence farmers can adapt to increasing thermal stress over, particularly towards the second half of the century. And there have been estimates suggesting that as a result of these stress, particularly in the summer months, there could be really quite major reductions in labour productivity. And of course that will have an impact on poverty. It will drive more people back into poverty, as well as having potentially direct health effects as well. So I think it's important to put in place adaptation strategies where they're relevant, but also to accept that there are some outcomes which it's going to be difficult to adapt to.
And this is very policy relevant. How do the policymakers answer to that and address this problem?
Well, if I could chip in following up on Andy's point, my impression at the IPCC meeting in Yokohama, where there was an opportunity to talk to a number of the government delegates, is that they are very interested in this idea of hard limits to adaptation, the point that Andy was making, that unless we're all going to live in air-conditioned pockets around the world, there are going to be hard questions about the habitability of parts of the planet under the high-end scenarios, and again thinking about what we might face in the 22nd century if there's no significant shift to the trajectory that we're following in terms of emissions. And hard end, by that we mean, the human body is limited in what it can do in terms of maintaining its heat balance once wet bulb globe temperatures get over 35 or 36 degrees, particularly if you're having to be physically active at the same time. So I think that this is a new aspect of the report. I think it'll get greater emphasis over the next few years as further work is done. And my impression is that it rings a bell with policymakers, this idea that there are things that we can't cope with, or only at enormous expense, and by absolutely transforming the kind of lives that we lead. And again, if I could just give an Australian example, in terms of hard limits to adaptation, I don't know whether any of you saw the Australian Open, the tennis championships in Melbourne in January, where you have some of the fittest people in the world attempting to do their day-to-day job, and it was too hot. And what the Australian organisers are absolutely facing is the possibility that it will be not be possible to hold the Australian Open in Melbourne in January in the future. And that is maybe an example of that general point that Andy was making about the importance of thinking about what we can adapt to and what we can't adapt to.
We have another question from a participant, and that is on malnutrition and food security, being an area that the participant says that it seems to be one of the newest and most interesting areas. That's the way he perceived it. And he wants to know more about the evidence. How strong is the evidence? It has accumulated, but how strong is it? He also wants to know about how come. Who would like to answer that?
Well, maybe I can start, and the
Mm-hmm.
others can add or correct me as need be. I think that's quite true, that the effect on food supply and food availability is one of the greatest concerns for people working in the area and for policymakers, and it potentially is one of the most important in terms of health, because obviously populations without secure food supply are going to be affected by health problems of many kinds. It's not straightforward to try and project what the consequences of climate change might be. There's a chapter on food security or on agriculture in the fifth assessment report, which goes into great detail looking at what the effects will be. And I think, in broad brush, their conclusions are that it's going to be, on current trends, increasingly difficult to feed the world's population in the second half of this century as a result of growing demands, as a result of what we know about crop production under high temperatures. Crops respond in different ways, different parts of the world will be affected in different ways, but in aggregate, overall, the stresses on the world's food production system are going to become very severe in the second half of this century. So I think it's not a new topic, it's something that previous IPCC assessments have alluded to. I think the amount of information that's available has certainly grown greatly, and the conclusions are voiced in a firmer style than they have in the past.
Anybody else who wants to comment on that?
I think it might be worth adding, just again from Chapter 7, and I would, as Alistair said, refer people who are particularly interested in this topic to Chapter 7, which does discuss the effects of climate change on agriculture in considerable detail. I mean, some of the statistics there are really quite telling in the fact that they, for example, point out that median yield impacts of up to -2 per decade are projected from the 2030s. And that's at a time when there's rising crop demand. So crop demand is projected to increase by about 14% per decade until about 2050, because of population growth and changing dietary patterns and so on. So you've got likely reductions in crop productivity at the same time as demands are going up really quite dramatically and steadily. And the other point that it makes is that we also got to consider not just terrestrial, not just land production of food, but also marine ecosystems. And they point out that because of ocean acidification, for example, but also because of the way in which climate change may affect the oceans, there may be substantial negative effects on fisheries, because we know that fish provides protein for perhaps around 1 billion people. And so there's certainly a need for more research looking at the combined effects of the disruption of marine ecosystems and reduction in crop productivity, and what that might have, the effect that might have on malnutrition. But even with the estimates that we have, that are probably quite conservative, they do suggest substantial increases in the number of children who will be stunted, for example, by the middle of the century.
Okay, thank you.
If I could just add one additional point on that, it's obviously a critical issue. I think one of the interesting things for me about the advances in science up to the AR5 is this better treatment of these interacting effects. And for example, one of the concerns about food and nutrition is the basically the combination of climate change putting agricultural yields at risk or hindering them in some parts of the world, with also the fact that we are not doing as well as we should have in lifting the poorest people out of poverty. So impacts on food prices are critically important, particularly for the poorest populations. And there's also another interesting point, I think, is the possibility of getting policies wrong. So it appears that one of the pressures on food prices is contributing factor is use of agricultural production for biofuels, supposedly as a climate change mitigation measure, and there's at least suggestive evidence that that is one of the contributors to food price increases, along with other things. And together, this is what makes the mix that has an impact on health and a differential impact on health on the poorest populations. So, as I say, I think the IR5 has taken us forward in terms of not seeing these things in isolation. It's not climate change or biofuels or energy prices. It's all of those things affecting certain parts of the population in a harder fashion than others.
Making this a terribly complex issue. We have a question that is more general in terms of impacts on health, and that is which groups are the most vulnerable to health impacts from climate change, and why is this? You've of course touched upon this already about the poorest populations, but could you expand on that as well?
Again, I'll start if you like. I think this is an area where there's a lot of information, and I don't think that AR5 tells a different story really to what's been reported previously. That it's populations that have few choices and few resources who are at greatest risk, and we can identify those without too much difficulty. It's to do with public health services, as we've talked about in some detail. It's about income, it's about education, it's about all those resources that enable people to cope with a demanding environment. I suppose the other point, and again it's a familiar one, but it's important to say all the same, is that it's not just the poor and the disadvantaged who are at risk, and of course that is the lesson from the heat waves in Europe, from the fires in Australia, from the floods and storms in the United States, that even affluent, well-resourced populations can be affected. So that's part of the IPCC message, I believe, that it's bad, it's high risk, and it's something that concerns us all.
We have a participant from US who thinks that this latest report downplays the risks on health in US. Is that so?
Yes, that's an interesting observation, and I think perhaps the specific example that the question might be alluding to is air pollution, and in particular the possible health effects of ozone, where in North America it's been projected that there will be quite significant negative effects if climate changes as projected. Whereas the global picture is more complicated. So I think that's the first answer really, is that the health chapter that we were involved in, Diarmaid, Andy and I, was trying to take a global view. There are of course regional chapters, including one on North America, which are focused particularly on some parts of the world. And the first working group 1, was unable really to give a clear signal on what's going to happen to ozone worldwide, because at higher temperatures the chemistry of photochemical oxidants is quite complicated, and you get both increases in ozone under some conditions and increased breakdown of ozone under other conditions. However, the effects in some regions are different. And there's some reason to believe, on the basis of various models that have been run, that in parts of North America, at higher temperatures, photochemical oxidants and ozone in particular will be an increasing issue for some urban populations. That's not true necessarily in Asia, that's not true necessarily in Africa. So that's the reason why we didn't emphasize air pollution, and in particular ozone, as a major issue in our findings. We were trying to balance up the effects around the world.
Okay. Any comments from you others?
Well, just to say that obviously the level of ozone precursors is also important. So methane is an ozone precursor. So depending on what happens to methane levels regionally and globally, that will affect ozone levels. So, for example, if there were, say, methane leakages from gas exploitation of gas, or if there was from positive feedbacks, for example, the natural sources of methane increasing the rates, if that happened, then that would also influence ozone levels. So one has to look at the whole picture, I think. The level of precursors as well as the climatic conditions.
Mm-hmm. Absolutely. We have a question from a person who are interested in the health co-benefits, and also asks about how is the potential for the health co-benefits to change the game, to actually have an impact and make people change behavior, and also policymakers make decisions that are important.
Well, I did try to outline some of that potential in my brief talk, but let me just sort of reiterate that taking into account healthcare benefits, of course, is important for a number of reasons. One is because many of the benefits are relatively near term. So obviously the benefits of mitigating climate change, preventing climate change, may extend over decades, even centuries, millennia. But many of the co-benefits can actually be quite near term. And that, of course, can make them more attractive to policymakers, who generally tend to have, often anyway, very short-term perspectives. Secondly, I think they're relatively predictable, because many of them are based on relationships that we understand reasonably well. We've got a lot of data on air pollution, for example. Both the sorry, I lost the connection there. Both in terms of PM 2.5s, but also increasingly black carbon and ozone. We know quite a lot about the relationship between physical inactivity, sedentarism, and human health, and we can make reasonably confident do modelling exercises to estimate the likely health benefits, for example, from urban transport strategies. We also know that many of these potential co-benefits are related to the determinants of non-communicable diseases. And non-communicable disease burden is increasing in many, many parts of the world, including low and middle-income countries. So increasingly, NCDs are becoming a concern to policymakers, not just in high-income countries, but also middle and even low-income countries. If you go to urban sites in Africa, for example, you see quite dramatic changes in disease distribution, often with a double burden of both infectious diseases and the non-communicable diseases. So these policies, if they're put in place effectively, can help to address a substantial proportion of this NCD burden. And the other point to make, I think, is that if one takes into account the economic impacts of some of these co-benefits, there are those for health, but there are also benefits for crop productivity, for example. If you reduce ozone levels or even reduce black carbon, you can increase crop productivity. So if you start to look at the array of co-benefits, not just in the health sector, then these can help to offset some of the costs that need to be spent up front in order to implement some of these policies. So obviously it does cost to move towards cleaner source of energy, or to redesign, to address urban planning challenges in order to improve transport systems. And taking into account, looking at the whole picture, can help to get a more rounded perspective, not just of the cost, but also the benefits of these policies in the near term. So I think properly implemented, they do have the potential to substantially add to the argument and contribute to the debate about the need to limit greenhouse gas emissions.
If I could just add a little to what Andy has said, particularly on whether this can or should be a game changer in policy terms. I think on the basis of the science, it certainly ought to be a game changer. As I said, the numbers are so big, the range is so diverse, and even on the specific issues where the evidence is clearest, on air pollution, for example, the numbers and the costs are so large that it ought to tilt any decision maker if you take these health implications into account properly. One of the things that struck us as we started to get involved in this area is that the barriers to doing this, to actually getting people to think about this differently, are more considerable than you would think, and they're not really so much related to the science. It's the way that people set these up as a policy question or think about them. And one of the illustrations of that, for example, is we looked at the major economic models that are supposed to inform policymakers on social cost of carbon, how much, to try and inform people about how much money they should be willing to spend on reducing greenhouse gas emissions. And out of, I think it was either 11 or 13 major models, only one of them had taken into account the healthcare benefits, despite their size, and that was the Stern Review. All of the others had just ignored it. And if you challenge these people on it, they don't have any good answer for why they've ignored it, other than basically that's the way they've always done it. And it's the same to a certain extent in people dealing with, I think, transport decisions or energy decisions. It's not that they don't believe the science, they may be unaware of the health science, and basically they've just not formulated the question in that way. And that's one of the things that we have to address, is actually it's going to take quite a while. I think that we have to work with these people to actually get them to formulate the question differently. I think that we are making progress, though. For example, two good examples of that. So Ban Ki-moon, the UN Secretary General, is calling a climate summit in September. In his one-pager, which publicized the summit, one of the main points he picked out on was these actions will also improve our health. He only said a couple of sentences, but health co-benefits effectively was one of them. The Executive Secretary of the UN Framework Convention on Climate Change, who runs the climate process, they had a press release welcoming the IPCC report. Again, they effectively mentioned healthcare benefits in the only couple of lines that they said. So I think people are getting this at the highest policy levels, and I think the public get it as well. If you look at the reaction to the high air pollution events in Paris and in London in the past couple of weeks, this was an issue that was really stimulating a public response. We know it's the same in China. So dirty air and wanting to clean up the environment does move people, and I think we have to support that with evidence, and also getting people to formulate the question in the right way.
Absolutely. We have lots of participants from the health sector, and we have a Twitter from a person who asks, why has public health systems not featured more in adaptation efforts and received more support? How can we remedy this? It's about the health sector's own responsibility and possibilities. What would you say about that?
I could have a quick go on that. I think it's certainly the case that the health sector has been somewhat slow to organise on this in policy terms, and I think that's part of the tradition of the health sector to focus on very much on curative action and on sort of individual diseases and the end of the pipe, basically. We don't have this tradition we should have in looking far enough upstream, or we've lost it to a certain extent. I think it's also the case that it has not been very strongly supported from the climate change and the environmental side, who have historically tended to see climate change as an environmental issue and as the preserve of the Ministry of Environment and so on, and have not been as active as I think they should have been in drawing in the health sector. Partly because they believe the health sector is a strong sector with a lot of resources that can deal with its own problems. And I think that has changed within the last few years. I think the environmental sector and the climate change people have recognized that health is a very strong argument, it's a very strong motivating force, it's an important issue, and also that the health sector has itself got itself better organized in terms of being more explicit about what kinds of public health interventions would actually constitute an adequate response to climate change. And I think, again, that's something that has changed over between the two IPCC reports, but we still have a long way to go.
Mm. Amongst the questions, we also have questions from young researchers, and they are, of course, interested in what is the most important research questions that we have to answer for the future. What would you say about that?
Well, my suggestion is to look at particular populations in particular circumstances, because I think the research opportunities very much depend on the context and the setting. There are, of course, some general principles. We've touched on some of these in terms of the limits to adaptation and in terms of the way health systems tend to operate and some of the challenges there that Diarmaid has alluded to. But particular vulnerabilities, particular opportunities for co-benefits, particular opportunities for cost-effective adaptation, I think they're to a large extent determined by the particular realities of populations and their geographic environments. So that would be my advice. Start local and think about how the global issues are going to affect the populations that you know well.
Mm-hmm. Diarmaid, do you have a recommendation?
To add to that, which I completely agree with, I think one of the things we should also be doing is to try to get more of a balance and, in terms of not just describing the problem, but also working much more on the solutions and the implications of those solutions. It was one of the things that came out of the World Health Assembly resolution in 2008, where ministers of health effectively asked the public health community and WHO to work on this issue, including on a series of research questions. There were 5, one of which was basically describing the problems. The rest were identifying interventions, working out the cost implications, decision support systems, and so on. So I think whereas most of the research output has been more on the describing the problem end. That makes sense in the early stages, but in terms of actually driving policy, a better spread across informing about what we should actually do about this, I think would be helpful.
Okay. And Andy, do you have a comment? A last comment. Time is running up.
If I could just add to, I agree with what's been said before, but if I could just add, I'd like to see some resources going into linking environmental and health data around the world. We're starting to do this in the UK, and there are substantial challenges, but there's a need for more of a worldwide effort, I think, to link environmental and health data so we can get a much better handle on whether some of the changes in disease distribution of climate-sensitive diseases is due to climate change, how much it is due to climate change, and other potential confounding factors or other environmental changes that are occurring simultaneously. I also think there's a need to evaluate adaptation policies because we have quite large assumptions about what works and what doesn't work. And there are some outcomes, like, for example, adverse mental health outcomes after flooding. We still don't really know what the right intervention for that is. And there's a real need for more primary research, I would say, to develop better interventions. And then finally, I think in terms of research on sustainability, because of the increasing urban populations, there's a real need to research better how we can develop sustainable, healthy cities which combine low greenhouse gas emissions with improved public health. And I think there are opportunities to embed evaluation into urban policies around the world. We see a number of urban administrations taking steps to reduce emissions, to promote healthier lifestyles, and to develop a healthier environment in the urban locality. So I would certainly place that as very high priority. And then finally, bringing together the food, the nutrition and agricultural sectors that often don't work together. They tend to work in their own silos. And so agricultural researchers are often concerned with increasing productivity without necessarily knowing whether that's affecting nutrition. And so I would argue for a much closer working relationship between public health, nutrition, and agricultural scientists.
Okay, thank you so much. Time has run out now, so I would just like to thank you so very much for participating in this webinar, and wish you all a pleasant night. Goodbye, or maybe not pleasant night, maybe. Depends on where you are. Thank you so much.
Thank you.
Thank you very much.
Bye-bye.